Good afternoon and welcome to today's webinar. Thank you for joining us. My name is Emily Haynes and I'm the Director of Public Health Initiatives at the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Protecting Babies at Birth, Recommending Hepatitis B Vaccine to Parents. I would like to review some information before we get started. The planners and speakers do not have any financial disclosures to make. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. In order to receive a certificate of completion, including 1 nursing contact hour, you must log in, listen to the entire webinar, and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. Today's program is being recorded and will be available on the partnership's website and YouTube channel until August 10th, 2023. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. So please write questions in the question box and we will address them at the end of the presentation with the speakers. Now I would like to introduce today's speakers. Dr. Joseph Schwab is an Associate Professor of Pediatrics at Rutgers, New Jersey Medical School in Newark. Dr. Schwab practices primary care pediatrics at University Hospital. He sees infants, children, and adolescents in an academic practice where he teaches clinical pediatrics to medical students, residents, nursing, dental, and public health students. Dr. Schwab's research interests include pediatric tobacco control, immunizations, and quality improvement. He also serves as chair of the Essex Metro Immunization Coalition. Dr. Schwab recently was appointed as the board chair of the partnership. Rosemary Bello Hornack has 27 years experience working as a certified nurse midwife, in addition to 12 years as a staff nurse in labor and delivery, mother-baby, and NICU departments. She is a childbirth educator and frequently presents to nurses and OBGYN residents. Ms. Hornack currently works as a staff midwife at St. Joseph's Medical Center. So Dr. Schwab, I'm going to just read the disclosure slide and then I'll start your presentation. So the planners and speakers, oops, go back to here, okay. The planners and speakers have no financial disclosures to make. Approval status does not imply endorsement by the Partnership of Northern New Jersey, NJSNA, or any commercial products discussed displayed in conjunction with this educational activities. Okay, Dr. Schwab, you can go ahead. Okay,
thanks, Emily. So I'm really happy to have everybody on for this lecture. It's something that I think is a very important topic. We're going to be discussing hepatitis B vaccine, and I'm going to start with a discussion of hepatitis B disease, the clinical characteristics, the epidemiology, and the available vaccines. And I hope to convince you that this is an important disease that deserves our attention, and that we should be making a strong recommendation for immunization for our patients, particularly infants at that birth dose. And then after that, I'll hand it over to my colleague, Ms. Hornack, who will discuss with you kind of the nuts and bolts of how to make an effective and appropriate recommendation so that we will be able to get the best results for our patients and their families. So next slide. So what is hepatitis B? Hepatitis B is a liver infection, and it's caused by the hepatitis B virus. The hepatitis B virus is a small double-stranded DNA virus, and we can, as clinicians, test for several different antigens on the viral surface that helps us decide whether an infection is acute, whether a person is convalescing, or whether they've developed chronic disease, and that will affect then our management and recommendations to the family. Next slide. So hepatitis B is an interesting infection in that it can produce both acute and chronic infections. Acute infections are ones that are occurring within the first 6 months. and these can be cleared, and a person can become infection-free and free of the virus for the rest of their life. These infections can be mild or severe. The younger the patient is, particularly infants and young children, often with their acute infection, they have little to no symptoms at all. So they may have something that looks like a mild virus, or they may have actually an asymptomatic infection. By contrast, these younger patients are more likely to go on to develop a chronic infection, being unable to clear the acute infection. If they do that, chronic infection produces a lifelong infection with active virus particles in the body, and that can lead to serious health effects in the long term, including chronic liver damage leading to cirrhosis, liver cancer, and even death. Next slide. So, hepatitis B varies depending on where the person comes from, and the number of cases are different in different populations. We know that there are more cases in patients seen in Asia, Africa, South America, and the Caribbean. And so in the United States, many of our infections are seen in immigrants who are coming from these areas. And again, as I mentioned before, many patients from these countries are infected as infants and never know that they had an infection because they were asymptomatic or very mild, and went on to become chronic carriers and can end up infecting their own babies in subsequent pregnancies later on. Next slide. So the incidence rate also varies in other groups. From 2009 to 2013, the combined incidence of acute hepatitis B infection in 3 states, in Kentucky, Tennessee, and West Virginia, increased over 114%, and that was found to be associated with increased injection drug use, which is another subset of population that is more likely to become infected with hepatitis B. So depending on where our patients come from and the family characteristics, we may see higher rates of disease in some of our areas. Chronic hepatitis B infection is estimated to affect between 850,000 and 2.2 million persons in the United States, most of these who have immigrated from endemic areas. And so it's not a small population that we're dealing with. Next slide. So a little bit about the clinical features of the disease. Once a person is infected with hepatitis B, there's an incubation period of anywhere from 60 to 90 days. And that's important because many patients then really can't recall exactly where or when they were infected, because they don't begin to show symptoms until 2 to 3 months later. As I mentioned, clinical signs and symptoms are more common in adults. Infants and children tend to present less of these symptoms. There is a prodromal phase, which is very non-specific. It lasts about 3 to 10 days, where you get a person with fever, malaise, anorexia, they have nausea and abdominal pain, and they may show some dark urine before they actually present with the classic jaundice. After the prodromal phase, they develop the icteric phase, where they have frank jaundice. The stools become very light in color. They do have an enlarged liver or hepatomegaly and some tenderness in the abdomen, and that can last 1 to 3 weeks before a patient goes on to clear the infection. Next slide. And then this convalescent phase lasts from several weeks up to several months. And so a person who's had an acute infection with hepatitis B can go on to have malaise and fatigue for several weeks to months, even after the jaundice, the anorexia, and the other symptoms disappear. Now, as I mentioned, most adults will recover from the infection, and most infants will progress on to chronic infection. The next slide. Okay, so about when an infant is born to a mother with active hepatitis B, chronic hepatitis B infection, the transmission rate is as high as 90%. So it's a very efficient virus for transmission. So we really need to pick up these infected women before delivery so that we know how to deal with them as quickly as possible after birth. For infants born and infected after birth, between 30 and 85% of them will go on to develop chronic hepatitis B, depending on the antigen status of the mother. Additionally, in addition to the perinatal transmission, the transmission occurs through exposure to other body fluids from persons with either acute or chronic infection. So in the United States, the most common and important routes are injection drug use, as I alluded to before, perinatal transmission, and then sexual contact with an infected person. Outbreaks have occurred in places like long-term care facilities, where poor infection control was practiced, related to blood glucose monitoring, and other things where blood and body fluids could be shared. Next slide. So as I said, about 40% overall of infants, it ranges from 30 to 85% of infants born to hepatitis B infected mothers will develop chronic hepatitis B infection, and 1/4 of them will eventually die from complications of chronic liver disease at some point in their life. Next slide. So the complications of having had an acute or hepatitis B infection include chronic hepatitis. Most of these patients are asymptomatic until they go on to develop cirrhosis, liver failure. There's a high incidence of hepatocellular carcinoma in patients who have chronic hepatitis B. And the proportion, again, depends on age of infection. So I mentioned 90% of infants. Even younger children who are infected between ages 1 and 5 years have a 30 to 50% chance of developing chronic hepatitis B versus 5% of adults who will go on to be chronic carriers of the virus. Next slide. So about 25% of children who are infected during childhood will go on to develop complications of chronic hepatitis B, liver cirrhosis, and liver cancer. And about 15% of them will die from their disease. Next slide. So what can we do about this? Thankfully, we do have effective prevention strategies to help when we have patients who are exposed to hepatitis B virus to prevent them from developing chronic disease and the complications that we talked about. The mainstay of our prevention is vaccination. And that relies on identifying hepatitis B infected pregnant women. So we recommend universal screening of women for hepatitis B surface antigen and antibody. We can provide maternal antiviral therapy during pregnancy if they have an acute infection. And then when an infant is born to a hepatitis B surface antigen positive mother, in other words, a mother who is a chronic carrier of the virus, they're given hepatitis B immune globulin and their first hepatitis B vaccine within 12 hours of birth. We also want to manage hepatitis B surface antigen positive mothers and their infants with effective case management, which will include follow-up long-term to assure ourselves that the infant has been treated adequately and has cleared their infection. Next slide. So we have several vaccines available. All of the vaccines for hepatitis B are produced by recombinant DNA technology. So a plasmid, which is a kind of a piece of DNA, is inserted into a yeast organism, and that places the gene for the hepatitis B surface antigen into the yeast, which then produces that antigen, which is presented to the person's immune system and elicits an immune response. All of the vaccines are administered by intramuscular injection. Next slide. And so the vaccines all contain yeast protein. They do contain an adjuvant, which Ro will talk about later, which does help the immune response of the body to the protein antigen produced by the yeast cell. And there's one newer vaccine called Heplisav, B, which contains a synthetic adjuvant. That's only approved for use in patients 18 years and above, so we don't use it in pediatrics. Some of the vaccines do contain Lasix, and then some of the vaccines that offer hepatitis B in combination with other antigens all do contain antibiotics as well. Next slide. So these are the different products that are available. The infants are all vaccinated using one of the two vaccines on that first line. It's a plain hepatitis B vaccine that's given for the birth dose. The next two vaccines, which combine hepatitis B with DTaP and polio, or DTaP, polio, and Hib, are available for use in pediatrics. And then the last two are available for use in adults who want or need immunization against hepatitis B. Next slide. The vaccines are very effective. We know that 90% of infants, children, adolescents, and healthy adults under 40 years of age will develop a very vigorous and protective antibody response following a complete series of the vaccine. And it's 80 to 100% effective in preventing infection or clinical hepatitis following a complete series in vaccinated patients. Some patients that have weakened immune systems, like patients who are on dialysis or who are immunocompromised for other reasons, might require larger doses or an increased number of doses in order to be protected, but they also deserve vaccination. We also know that although the antibody response will wane over time if you try to measure antibodies in the blood of a patient who's been vaccinated, the immune memory remains intact for more than 30 years after vaccination. So it's a very effective vaccine. We give it in infants and finish the series by hopefully 6 to 12 months of age. And we expect that that infant will be protected from an infection for most of their young adult and into their early adult years, and probably beyond there. There are no booster doses recommended for hepatitis B at this point. Okay, next slide. So who should get the vaccine? First of all, the people we're talking about today, all infants should receive a dose of hepatitis B vaccine within the first 24 hours after birth. Children and adolescents who were not previously vaccinated should also be universally vaccinated against hepatitis B. Any unvaccinated adult who has a risk factor for hepatitis B should be vaccinated, and an adult, even without a risk factor, who requests vaccination is eligible to receive the vaccine. So adults, which adults are at risk for hepatitis B that might want to be vaccinated if they hadn't been previously? These include adults who are at risk of hepatitis B from sexual exposure, if they are household contacts of persons who have hepatitis B surface antigen carriers, who might be at risk of exposure through either percutaneous infection or mucosal exposure to blood. Patients with end-stage renal disease should be vaccinated, as well as patients on hemodialysis, patients with diabetes between 19 and 59 years of age, persons with hepatitis C infection or persons with chronic liver disease should be immunized against hepatitis B, and certain people who are expecting to travel internationally and haven't been vaccinated before would also be eligible for the vaccine. Pregnancy is not a contraindication to hepatitis B vaccination. So if a woman is at risk for hepatitis B infection because of, for example, multiple sexual partners or injection drug use, and they haven't been vaccinated before, they can be safely vaccinated during pregnancy to protect them and to protect the baby. Next slide. There are only a few contraindications. This is a vaccine that's very well tolerated. If anyone has had a severe allergic reaction to one of the vaccine components, like the antibiotics, or if they have a hypersensitivity to yeast, then they may not be eligible for the vaccine. And then there's a general precaution against the vaccine if there's a moderate or severe acute illness, in which case it might be worth, depending on clinical decision making, delaying the vaccine until they get over their acute illness. and that decision should be made in consultation with the individual's provider who's caring for them. Next slide. And so these are some of the side effects that you might see, and you see the numbers are very low. There's a low incidence of pain, anywhere from 3 to maybe 29%, a little bit of redness and swelling at the injection site, a very low incidence of low-grade fever, and some headache. There were some reports of Guillain-Barré syndrome, which we see after many of the viral vaccines. However, it's been very rare, and there's been no way to establish a causal incident association between receiving the vaccine and the Guillain-Barré because the incidence is so low. There was also reports of hepatitis B vaccine triggering alopecia or hair loss. However, studies also didn't find any statistically significant association between alopecia and hepatitis B, but that may come up when you're speaking to patients if they've read a little bit about the vaccine. And then the next slide just goes through the schedule that we recommend. So what we're talking about today is the first dose within 24 hours of birth, the birth dose, which will be given in the hospital after delivery. That dose should be given as early as 12 hours if the mother is a carrier or chronically infected with hepatitis B and is positive for the surface antigen. And all babies who are born to surface antigen positive mothers should strive to finish the series by 6 months of age, which is the recommendation for everyone. The third dose can be given anywhere between 6 and 18 months of age. And that third dose needs to be given at a minimum of 24 weeks of age, so just shy of 6 months. The usual schedule is the birth dose, a second dose at 1 to 2 months of age, and then a third dose at 6 to 18 month age. It is important if you're giving combination products that include other vaccines that are given at 2, 4, and 6 months, that we give that extra dose of hepatitis B, but that 4-month dose wouldn't be counted as part of the series because it's below the minimum age for the final dose. Preterm infants also would be vaccinated at birth. However, if they're under 2,000 grams and the first dose was given before 1 month of age, that dose is given but doesn't count, and they would still need 3 additional doses, with the first dose of the official series being given when they turn 1 month. So they'll get it at 1 month, 2 months, and then at 6 months of age after that. And then one more slide. So follow-up after vaccination is not routinely needed. The real only exception to that is infants who are born to hepatitis B surface antigen positive women, or if their antigen status is unknown, then they would be tested for hepatitis B surface antigen as well as antibodies to prove that they mounted a good response to the vaccine and that they were not chronically infected, because we know, again, most of those babies, even if they were infected, would be asymptomatic, but it would be important for us to know whether they're going on to be chronic carriers. The effectiveness of the vaccine is quite high, so that transmission, which would have been between 35 and 80%, is down to below 1% transmission and closer to 0.1% in babies who receive the vaccine after delivery. And then the last slide is just some websites that I used to prepare this talk, and also they're good resources both for clinicians. They have information for professionals, and particularly on the CDC websites, they've got a lot of information geared towards patients and families that is available free. You can download it, print it up, and use it when you're educating your families about hepatitis B. So hopefully I've proven to you that this is an important disease, a serious disease, that vaccines are effective, that they're safe, and that we should be recommending this dose to our babies and their mothers when the babies are born. And I'm going to turn it over now to Ro to discuss with you how to go about making an effective recommendation.
Thank you, Dr. Schwab. Hi, everyone. Well, I know I'm convinced by what Dr. Schwab has just said, but what I'm here to discuss with you today is how to discuss, convince your parents of these babies that will go on to be children and need to receive vaccines throughout their life. Next slide. We can actually get, I'm so sorry. So this is where I'd like to start. Sometimes a cartoon says it all. This is actually something that was being circulated during our COVID time, and I thought it was just so appropriate for today. And you can see the little boy, the child is asking, "What's that mark on your arm, Mom?" And Mom is saying, "It's a smallpox vaccine scar." And the child is asking, "Why don't I have the scar?" And the mom says simply, "Because it worked." Smallpox is the only disease that we have eradicated, and this is it's amazing what 63 years, the change that 63 years has made. The World Health Organization between 1958 and 1977 developed a campaign to eradicate smallpox, mandating that everyone have the smallpox vaccine, and it's done its job. So this is not, the smallpox vaccine is still being manufactured for different types of diseases that may come up, but it is really not, we've taken care of it, which we could be doing with COVID. And next slide. In talking about that, whenever someone says vaccine now in your, you start to bring up that topic, it is a hot topic of the day. So you being the provider, they are looking to you for guidance, for answers, for advice. What I suggest, and we're talking about a very proven vaccine here, hepatitis B, but I will get on and discussing in the slides moving forward that we are really helping out the pediatricians. Just in speaking about hepatitis B, we can delve into some of the other vaccines if they have some questions. But try and look up the vaccines or the medications that you're discussing with your parents, so that it's not coming out as if it was a script. You're not scripted. You're using conversational language and really just trying to gear the conversation in a way that you know that you've hit all your topics, but really try and look up what you're discussing with your parents, the pros and the cons, what may come up in the discussion. And at St. Joe's, I have looked up our acceptance rate here. We are starting to discuss it during our pregnancy. Just doing this in developing my my slides here, I've decided that we're going to start talking about it in the pregnancy also. But right now we have a 99% acceptance rate, just talking to the moms and the parents, moms and dads, on the floor, postpartum floor, mother-baby floor, when the baby is born, and it's a 99% acceptance rate. So hepatitis B, I don't think, is really one of the vaccines that is questioned by the parents, but you should be prepared. Next slide, thank you. How to start the conversation. So what I had suggested for our clinic is that maybe we start at 27 weeks when we're talking about the Tdap. Just saying that word vaccine, you know, well, I know the flu vaccine is coming around, but just knowing that we all you know, in your mind, you have a checklist of what you'd like to talk about during the pregnancy. Speaking about it with the Tdap, you can mention to them, do you know that your baby is having 3 medications within that first 24 hours of life? The vitamin K for the, the erythromycin for the eyes, the gel, and you should mention that they'll be given their baby after birth, and they'll see that they have gel in their eyes. Don't wipe it away. Let it naturally work its way in. Vitamin K for the ability to have, for the clotting factors that the babies are not born with. And then mention hepatitis B within that first 12 hours. It's a good time to mention it, like I said, during Tdap, and then revisit it when you have your mom at 36 weeks, because you have 4 weeks thereafter. If there are any issues, you can touch upon some of those points. ask or handouts versus social media is a big topic. We here at our clinic, we love handouts. We have them in Spanish and English. As Dr. Schwab mentioned, and I'll mention again later in the slide, the CDC has a vast amount of handouts that you can download for free, and they're wonderful. They're in plain language, layman's terms, and I really think that they've done a wonderful job on helping us teach about vaccines. But ask the parents, if there does start to be an issue, where they're getting their information. Just know that most people today are Googling or using YouTube very often to get their information. And when you use this computer or this phone and you start to ask questions or just be in a neutral way looking into vaccines, depending on which way you're then clicking, maybe it's the AntiVax that has the parents' interest, you will then go down an AntiVax algorithm within your computer or your phone, and vice versa. You can be pro-vaccine if you've decided to go that way. So you do have to make sure that your parents are understanding that they need to make sure that their sites and what they're looking at are valid, and they're not going down that propaganda rabbit hole. And I had mentioned before, just make sure that you keep it very conversational, read enough that it's just rolling off your tongue, and be very, very empathetic. Sometimes people have a story to tell. And I know that our visits we have our patients for a short amount of time. Try not to cut them off. Listen to the story, and again, be empathetic, and then hit upon some of the points that you may want to drive home for that visit. Can I have the next slide? Okay, so when to start the conversation? Here at St. Joe's, we do have a fair amount of patients that come in with no prenatal care, but this is not a conversation for anything that you want in that time of duress. So try, as I had said, have it in labor. I mean, have it in the prenatal time starting at 27 weeks. If you do have to have it in labor with the no prenatal care patients, do it at a time, unless they're in a really active phase when they enter. Try and just make sure that you're touching upon it, seeing if they know that their baby is going to receive, like I said, the 3 vaccines, the 3 medications in that first 24 hours of life. With my Tdap, when I discuss it with patients, is this could be the first gift that you could be giving to your baby. That immunity, getting it at 27 weeks, having it go through the placenta and giving your baby until it receives its Tdap, that first gift of the vaccine and that immunologic effect. So with the hepatitis B, this could be the second gift that you're giving to your baby. And again, I think I pointed on those other 2 points. Be conversational, be empathetic, and revisit it at 36 weeks to see if there's anything that needs to be discussed. You may think it's just the provider that the patients are asking. You really should get your front desk staff involved with this conversation. The medical assistants, absolutely, I apologize, and the nurses that are working with you. The parents, you may be giving them the information, but then later on they may be just scouring around to see who else might have some advice to give involving all these vaccines that they're receiving. If you're taking care of a clientele that's lower socioeconomic, they really very often don't have the access that the higher socioeconomic population has, and that population are the ones that are typically very anti-vax, and they feel that they know better, they have more information about it, and so you may think that the lower socioeconomic are going to give issues, but it very often is the complete opposite. Go to the next slide. Again, knowing your facts, letting the parents know that the CDC is constantly monitoring vaccine side effects, and some of these organizations that are put together to make sure the vaccines are staying safe. The VAERS, the Vaccine Adverse Event Reporting System, this monitors potential problems, and anyone can call in. You do not have to be a provider or be connected to a pharmaceutical company at all. Anyone can call in and say, there usually is a number on the back of the, within the information for the vaccine, that you can give a call and say, I've had X, Y, and Z, and it's the pharmaceutical company then to figure out, it's their job to figure out if this is a side effect that's connected to the vaccine or something that was just incidental. The vaccine safety data link, that is a collaboration of 9 healthcare organizations, and they are actively researching vaccine safety. The Clinical Immunization Safety Access is a partnership with the CDC involving 7 research centers, and it conducts constant collaboration and research on vaccines. So these are 3 collaborations or partnerships that you can tell your parents about if they're truly thinking or in the way of anti-vaccine, that you can make them feel assured that the safety of the vaccine is being constantly looked at, and it's an ongoing procedure. As Dr. Schwab had pointed out, there is not a small virus, but there is a gene that's put into the adjuvant for whichever vaccine that you have, and that is going to spark an immune response. And I always mention it to my patients. I try to put it into a fun way that they may remember. It's now building up warriors against that virus. And also mention that many of them are multi-dose. Well, multi-dose meaning they'll need more to complete the series. And I think Dr. Schwab had mentioned that you know, some of them, when they are later vaccines, they could have antibiotics in them. You can have the next slide. So speaking about the adjuvant, with the anti-vax conversations, these are the hot topics that are going to be questioned. And again, looking into them as much as you can would really help. The aluminum, the amount of aluminum and yeast in some of the vaccines, they are trying to make them smaller and smaller. But as Dr. Schwab had mentioned, hepatitis B, what we have to concern ourselves with is the yeast. Later on, people may be mentioning mercury. Mercury is always a hot topic with vaccines. That's more for the multi-dose vaccines that we're giving, like the flu vaccine. But again, through time and the making of the vaccines, they are trying to really lower that mercury preservative that's put into it, the thimerosal. Moving on to the autism, this is more of the MMR. But again, and I know I'm jumping to a different vaccine, but like I had mentioned, when you're talking about vaccines, even when it's just the hepatitis B, parents still may have that question. And the big elephant in the room, the COVID vaccine, they may ask you some questions about it. We are helping out our pediatricians. We're helping out our fellow workers within the healthcare system and trying to thwart some of those issues that may head them down that anti-vax rabbit hole. But autism is more connected with the MMR when you look it up in the research, and that has been thoroughly researched. There is no connection to autism and the mercury in the MMR. What has happened, unfortunately, is that is the time when the MMR is given for the child that autistic features do present themselves. So very often autism has been connected to the MMR because maybe they've just received it. And again, if someone starts to tell a story, you know, I have a neighbor who had an issue, listen to their story, don't cut them off, listen to them, and then very confidently, you know, with knowledgeable words, tell them how it's truly been studied, and there seem to be connections, but it has been studied profusely, and there is no connection with autism and vaccines. And let them know that each vaccine ingredient plays a part, plays a vital role in the manufacturing of the vaccine, how the vaccine is, how the antigen is getting into the patient's system and then causing a reaction against the virus. And just ensure them that we are really trying to protect their child. Nothing that we're giving them is not going to harm them. It's going to protect them. I think, no, I'm sorry, the last two things. Are these diseases dangerous, and do they still exist? Most of your couples will maybe remember measles, which was a hot topic back in 2010. Measles has resurfaced because of the anti-vax communities and a lot of people coming from overseas. And again, that no prenatal care population maybe have just come from overseas. The measles was really under 100 cases that we were seeing, and back in 2010 there were 15,000 to 50,000 that year. So other countries and the anti-vaxxers unfortunately were the reason for the measles outbreak back in 2010. So yes, it is important. We don't want these. We'd like everything to be like smallpox and be eradicated. So that's why we're encouraging people to continue with vaccine use. You can have the next slide. Don't be afraid to say to your patient, because you never, a question may come up, you know, that you'll get back to them on a certain topic. And again, you know, I don't mean to keep beating this, starting at the 27 weeks and then revisiting it at 36 when you see them every week can give you that opportunity to write in the notes, specifically see that person yourself, or call them and get back to them with that answer that you may not have had the answer to in the visit. Again, we're helping out our fellow pediatricians for later on. Hopefully we'll convince them enough with hepatitis B that any other vaccine will just, that there won't be an issue, and they'll understand that they truly need it. Websites are the best if people want to go for websites. Again, we here in the clinic love our handouts so that we can control, not to say that we're brainwashing them, but we know what they're looking at when we download our CDC handouts and we're handing it to them. But if they do insist on a website, the CDC website is very user-friendly, uses layman's terms, and answers all of the questions that the parents may have. And I think my, and one more thing about the CDC, we mentioned it was down, it was a free website. Definitely download them for your clinic, very inexpensively, so that you know, you can make that part of that visit. And I think the next slide is just my references that I have used, mainly CDC. If anyone has any questions, that's where they can go. I think that's it.
Great. Thank you so much, Dr. Schwab and Ms. Hornack, for wonderful presentation today. We do have questions coming into the question box already that we will moderate. And we also, just as a reminder, if you have questions for the presenters, you can submit them in the questions box, and we'll address them now since we have some time. So the first question, I guess it could be maybe for Dr. Schwab if you want to address this. How much protection is lost if a family requests waiting to give the birth dose at the first pediatrician appointment?
So the baby should still develop an effective immune response with the dose given at that age and following the schedule. So it would delay the protection until the series is finished, which means that the baby would be protected for that first month. That's particularly important if a mother is at higher risk and maybe was infected with hepatitis B after she was screened, and you don't know that the baby might have been exposed, or if there's other potential exposures. And then also they're not fully protected until later because they wouldn't complete the series until a month or two later. So I think what we're striving for is that universal birth dose within the first 24 hours is really going to be the most effective.
Okay. So I think this question's again probably for Dr. Schwab based on his presentation. So it goes back to the level of protection for the birth dose. Is there a difference for outcomes for infants? You mentioned that there's a 35 to 80% chance that the child will have chronic disease or transmission. So is there a difference in the transmission rate for newly infected during the pregnancy, or if the mom had been hepatitis B antigen positive prior to conceiving?
Yeah, that's a very good question, and the answer is yes, there is a difference. So one of the things I mentioned earlier on in the talk is that the clinicians can measure different antigens and antibodies that are presented by the virus at different phases of an infection. So there's the E antigen, the C antigen, the surface antigen are several of the ones that we commonly measure. And when you look at those in different stages, it tells you where in the infection a person is, whether it's brand new, whether it's they're convalescing, or whether they're chronic carriers, and where in between. And that also affects then how transmissible the virus is from the mother to the baby perinatally. And so looking particularly at the E antigen, the transmission from mother to baby ranges anywhere from 30 to 85%, I mentioned, and that really depends on how active the mother is in terms of the amount of surface antigen, particularly related to that and related to the E antigen. So I don't know if that was too complex an answer, but in short, the answer is yes. And it depends, and it can be measured, and you can give a mother a more particular risk based on the lab studies that you do.
Okay, so and so for women with no prenatal care, like Ro had mentioned in her part of the presentation, the universal dose is given because we don't know if that mom has an active infection or not.
Right, a universal dose, and if the mother is either unknown or is surface antigen positive, the baby also gets immune globulin, which will help. That's kind of a form of passive immunization that will neutralize the antigens and hopefully prevent an infection even before the vaccine has a chance to help the baby develop their own defenses against the infection.
Thank you. So this is for both presenters. How has the COVID-19 pandemic impacted vaccine acceptance? And in particular, do you think it has impacted hepatitis B birth dose acceptance, whether positive or negative?
For me here, or for our clinic here, I'm finding that our clinic population is really 50-50. I think as of late, people are more accepting, even getting the vaccine during the pregnancy. I don't think it's affected the hepatitis B at all. I think it's trusted. It's a trusted vaccine, really no question. But the COVID is just, it can really cause such a response in a patient just speaking about it. In the beginning, people weren't open to getting it during the pregnancy, and now I'm finding that more and more people are. They're not so. We have the Johnson & Johnson vaccine here, and if they're not comfortable with that, we just suggest that they go to another source, CVS, Walgreens, and get the other types of vaccines that have the 2-dose.
Thanks, Ro. That's very true. One of the things that we've seen is actually pertaining more to access. And so because of the COVID pandemic, especially earlier on, many families were reluctant to bring their kids into the pediatrician's office for routine care when they weren't sick. And so we were very concerned, and the numbers did go down initially in terms of kids getting their routine vaccines because of the COVID pandemic, more just because they didn't come in at all and be exposed to potential COVID. This is even before the vaccine was available. One thing that we didn't mention that maybe we can bring up is, because some of our hospitals might be seeing more of this, is that New York came up with a mandate that all babies will get the hepatitis B vaccine at birth. And because of that, we've been seeing an influx of mothers who are from New York, but come across the river to New Jersey to deliver because they're still able to decline the vaccine. And so in some of our hospitals, especially along the border, we're seeing lower rates of hepatitis B. And some of that is due to policy. So we do know that policy affects vaccination rates. And that's one way that our numbers have been affected kind of negatively.
Okay.
Well, clearly they're not coming to St. Joe's with our 99%.
Ro, I think this question would be for you. So for staff nurses in the labor and delivery units, when would you suggest is a good time for them to address vaccine hesitancy, maybe for a patient who is refusing the birth dose or seems hesitant about it? You mentioned in your presentation that during labor is not the ideal time to have provide education, but postpartum, when would you suggest that a labor and delivery nurse or a postpartum nurse approach the parents about that conversation, and how would you suggest that they do that?
If someone truly is an anti-vaxxer, sometimes they make that known from the beginning. So in that case, in labor and delivery, if you're a labor nurse, you could mention it during that latent phase, in the beginning parts of labor, when someone's just breathing, the contractions are not that close. It would be a good time. That sometimes you're at a loss for what to really talk about if you're in the room, or when the baby's born and they're nursing, you're all looking at the beautiful baby and mention, let's just maybe think about revisiting that. And maybe they have or have not had any issues with the vitamin K or the erythromycin, but if they haven't had an issue with that, and then they think that they have an issue with the hepatitis, mention that you just helped your baby out in 2 ways. Wouldn't it be nice to help out also with the hepatitis B? Provide handouts, and again, point them in the direction of the CDC website. So I would not do it in an active phase. You just won't be able to get a word in edgewise, but certainly during the latent phase, and then immediately postpartum, when they're breastfeeding.
Thank you. Another question for Ro. What is an example, or could you give an example of how to be empathetic to patients when having a conversation?
Teaching someone how to be empathetic is just, being a real person, listening, I guess would be the main thing. And again, hearing that story out. If someone has a question or a story of something that they've heard, or someone that they know, maybe something even really personal, maybe they've had a child that had a reaction in some sort of way, hear the entire story out, take a breath, and then answer it. Don't cut them off and say, no, knowing that what you probably know is the end of the story. No, that's not what happened. Hear them out with the entire story. Just listen, take time. We tend to try to move through all our tasks during our visits. Just take some time, take a breath, and listen, talk to them.
Thank you. Everybody wants to feel heard and validated.
Mm-hmm.
Another question: What do you hear as the biggest reason for parents to decline a birth dose vaccine?
We haven't really had anyone. I think if anything, maybe I have heard in these years that it's just so much for the baby in that 24 hours. Can we just slow it down. You know, we are giving 3 things right within that 24 hours. So that's the biggest concern that I think I have heard at some point, not a lot, but that it's just so much so fast.
Yeah,
And we did have a short time that we were doing circumcisions in the delivery room to free up the residents or the doctors from their duties postpartum in that postpartum time. And so that's even, you know, more worrisome for the parents. You know, to have all of that done in 24 hours.
And do you recommend that the hepatitis B vaccine could be given while the infant is breastfeeding or doing skin to skin if the parent asks for that?
Sure. If they need it within the first 12 hours, absolutely. They could do it during skin to skin. Very often we give some of the vitamin K. Well, it's hard to do the eye drops, but vitamin K is done during skin to skin. If they insist, or we just have that time and we don't have many people in labor, absolutely. And it helps to soothe the baby when they're skin to skin. But if they need that first dose of hepatitis B in the 12 hours, for sure, that would be ideal.
Great. This question is for Dr. Schwab. Can you please explain more about what are adjuvants?
So yeah, adjuvants are chemicals that are added to a vaccine that make the vaccine more immunogenic. It makes the body respond more vigorously to the part of the vaccine that you want it to respond to. So in this case, the hepatitis B antigen that is presented on the vaccine that you want to make antibodies to is coupled with aluminum, and the aluminum just jump starts the immune response and makes it more vigorous.
And so another part of that question is, how would someone know if they were allergic to an adjuvant?
Most of the time, I mean, allergies to something like aluminum is the most common adjuvant, really is not a very common allergy. Most of us are exposed to aluminum at much higher rates than the amount that's in a vaccine. And so the concerns I think about aluminum as an adjuvant in vaccines are not really related to allergies. Most people bring it up as a concern of what it will do to the immune system, cause autoimmune problems. They have a lot of things that they think maybe aluminum does affecting the brain, dementia. There's different things that they are worried about, none of which really has been linked to the tiny amount of aluminum that's in the vaccine, and that's in it for a very good reason.
Great. And one final question. We have time for one more. So I think this question may be for Ro, but Dr. Schwab, if you have input or last word. Ro, for staff nurses in postpartum that say that there's not enough time or there's too much happening in the postpartum period to be able to deliver the birth dose on time, what would you recommend to them so that they could make sure that they prioritize hepatitis B, or why should they prioritize hepatitis B vaccine?
Well, for sure, if they're talking about the 12 hours, I think it's obvious why they need it. The mom is infected, so this is a crucial vaccine to receive. And on the postpartum floor, on which I've worked on all units, there is definitely a time within that when you're being introduced to the patient, they're coming into the room, mentioning it then and saying, these are the first few things that we need to have done, because now it's usually, I think most hospitals are a mother-baby experience. So that would be the first thing. Let's talk about it. Here's the consent, some information you can read and a consent. And I would absolutely get that done first, have that done and dusted before you're getting on to some of the other things that are important in that postpartum time. But for sure, if someone's infected that first 12 hours, make that your first priority.
Thank you. So that's all we have time for today. Many thanks again to our speakers and Karen Amadeo, who's handling the technical background of this program. And thank you to all of you who have joined us today. So a reminder that you will receive a link to the post-program evaluation, and your feedback is important, so please complete that. And certificates of completion will be sent via the email you provided on the evaluation. And you should receive those in about 1 week. A calendar of the partnership's upcoming virtual programs can be found at pmch.org under the Professional Education tab. And we also offer on-demand recordings of many of our programs. Thank you, and we hope that you can join us again for one of our upcoming educational programs.
Thank you.
Thank you. Thanks.
Bye.
Bye-bye.
Bye.